everybody, Tanya Finkbeiner joining you again tonight. I am the Chief Development Officer for the Purdue University College of Veterinary Medicine. It's exciting to be here again with the Coin Veterinary family and to introduce one of our students and clients' favorites, Dr. Stephanie Thomovsky. Grab a pen and paper and take some notes as she talks us through some interesting neurology facts and tidbits for the canine owner. Thanks.
Hello, my name is Stephanie Thomovsky. I'm excited to speak with you guys today, and we are going to be discussing today common neurologic tricks of the trade and facts for every dog owner. And yeah, I'm pretty excited to speak with you guys. My role at the university is to instruct the veterinary students on both clinical neurology and neurosurgery, but also on physical rehabilitation. And I also see clinical patients as well, and in doing that, teach students while we see the clinical patients. So I'm really excited to meet you guys here today. Maybe I've even met some of your dogs and cats. So we'll just get started. All right. So first we're going to start out by discussing sort of kind of common diseases that we in veterinary medicine share with human medicine. So we're going to talk about disc disease, we'll talk about strokes or cerebrovascular accidents, also known as CVAs, and also discuss seizures. Mainly with regard to seizures, because I don't want to scare anybody and show a bunch of seizure videos and things like that. That can be a little off-putting. But I thought I'd discuss a little bit of facts about seizures and also just sort of at-home management for you guys to think about if you happen to, God forbid, have a dog or cat that starts to seizure. I will say that today's focus is mainly going to be on dogs. That is the most common clinical patient that we see in small animal neurology. We definitely see cats too, but probably one for every, I would say, 8 to 10 dogs. So we definitely see dogs a bit more commonly. All right, let's get started. So what is disc disease is what you guys might ask. So disc disease is also known as intervertebral disc disease, or IVDD. And this is equatable to what we call in a human, or what we refer to in a human as a slipped disc. And I'm sure you guys have all heard that before. I'm sure you've even commented that my back hurts and you assume that it's a disc problem in your own back. It's a pretty prevalent issue. Just to give you guys some anatomy here, we've got the dorsal spinous process, which is the top of the vertebrae, the articular facets, we have the spinal cord, the nucleus propulsus is the inner part of the disc, and the annulus fibrosus is the outer part. So you've got the bone, which basically we call the vertebrae, spinal cord. If you guys remember way back when from biology, it looks like a butterfly. So we have sort of the neurons live in the gray matter of the butterfly, and then the white matter out here is where the axons live. And both those things basically transmit information down to our lower limbs and to our, I should say, lower and upper limbs in our case. And then we have the disc, composed of the outer annulus and the inner nucleus. So what happens when a disc slips, also known as herniates? Well, or protrudes is the other terminology that is used. So most of the time in human medicine, we actually end up having protruding discs. So we have this idea that we have a disc, we've got a spinal cord, we've got our vertebrae, right? This particular image, we've cut away the bone around the spinal cord. Here's sort of a cross-sectional view, so going basically right through here is now the view that we're seeing here. And what you guys can see is here we've got some disc material, and that disc material is pushing up on the spinal cord, right? And it's impinging the spinal cord, pinching the spinal cord. And so we can either see that in the form of a protrusion, so where the actual nucleus, the inner part of the disc, pushes up on the annulus, which then pushes up on the spinal cord and protrudes. Or we can see an actual herniation, which is what this picture is trying to depict. So the idea that some of that nuclear material, that inner part of the disc, is actually herniated, has left and pushed through, extruded past the annulus, and is now putting pressure on the spinal cord itself. And so these are both things that we can see in veterinary medicine. In human medicine, we can see either as well. Oftentimes, protrusions, I think, are a bit more common in us, though. So why do we care? Well, that slipped disc can lead to this kind of posture in us. We've all had that. So where you bend down, you stand up, you have this extreme pain in your back. If I could see you, I bet you would be shaking your heads right now at me, saying that you've experienced that yourself or seen someone experience that. You might even have more dramatic signs than that, and those dramatic signs could be anything from, starting to not be able to feel your limb, feel your pelvic limbs, for example, or perhaps dragging a limb or starting to stumble on a limb. But by far and away, the most common sign we're going to see in humans is going to be that back pain, that kind of recurrent, kind of obstinate, kind of continual, or sometimes even intermittent, but back pain. Now in a dog, the clinical presentation, the typical presentation is going to be this guy right here. So dachshunds by far and away are our poster children in neurology. It's one of the more common breeds that we see, mainly probably because they're what we call a chondrodystrophic breed. So meaning that they have short little legs and a long disproportionate body. Those dogs are predisposed to disc degeneration, loss of hydration of the disc. If it loses hydration, it lacks some of its shock absorption, and as a result, they're more apt to develop disc disease. Now, we're going to talk a little bit today as to why there's this difference in presentation. So why many times in humans it presents as back pain, but many times in dogs it will actually present as either extreme weakness, which is the term we call paresis, or plegia, which is the term meaning paralyzed in the back legs. In this little guy's case, he definitely has paralysis. You can see he's kind of not aware of where his limbs are, and they're being held out back behind him. I don't want to give you guys the impression that we can't see back pain in dogs. We certainly can, but they definitely, more commonly than humans anyway, will also present with varying degrees of weakness to paralysis in their pelvic limbs as well. And today we're sort of centering more on what we call thoracolumbar disc disease, so disc disease affecting the back part of the back, here in us. We're not going to focus as much today on cervical disc disease. So there are some anatomical differences, and the kind of sum of this talk is going to be that anatomy matters, so it's the crux behind everything here, and the big differences between everything that we experience between our human patients and our veterinary patients. And so looking at a person, we've got the cervical spine, we've got the thoracic spine, lumbar, sacrum, and then we have the coccygeal vertebrae. So cervical spine in almost nearly every single species, even humans, to dachshunds, to cows, to pigs, to horses, to even giraffes, we can actually see 7 cervical vertebrae. So that's a very common thing. Thoracic vertebrae, they have 12, 5 lumbar vertebrae, and then they have 5 sacral vertebrae. When it comes to canines, they also have, as I said, almost every single species has 7 cervical vertebrae, even the giraffe. They often also have 7 cervical vertebrae, 13 thoracic vertebrae, 7 lumbar vertebrae, and then 3 fused kind of sacral vertebrae as well. And so what the point of talking about this is that, we're not that different when it comes to vertebrae. It's what's within the vertebrae that matter, the spinal cord itself. There's going to be a difference there between humans and animals that will lead to our differences we see with this disease. So let's compare the actual disc. So here's the picture of a human vertebrae. Here's a picture of a canine vertebrae. So you can see both have a dorsal spinous process. That's the part when you feel down your back, the bump you feel on your back, that's what you're feeling. Here is this bone. So this is dorsal, or on the top of the back. When you touch the top of your little dog's back too, that's what you're feeling. These are called the articular facets. You notice they look quite different between species. So these are the bony junction or joints between the vertebrae. And then you guys can see the spinal cord here and the nerve roots coming off the spinal cord. Here is not a good depiction of that, but they would exit in the same way. So the nerve roots would basically come off from the vertebrae in the same exact location that they come off in humans. And then the disc. So in veterinary medicine, the disc anyway is located, the nucleus, the center part of the disc, which many times the disc is described as a jelly donut with an outer component and an inner kind of gooey component. That inner gooey or well-hydrated component in a normal disc sits in the dorsal third of the annulus. So one of the reasons why disc protrusions happen up and happen towards the spinal cord rather than down or to the sides is there's a path of least resistance there. There's less annulus dorsal to the disc, so less annulus from here to here in a dog, and so it's easier to bust through that and ultimately to impinge on the spinal cord. So over here is the same picture but in a human. And so really when you look at these side by side, they're not all that different really. So more has to come into play here then that would define why we see kind of the differences clinically that we do. So why is there this difference, right? Why do we typically have back pain rather than paralysis and paresis? And why do these guys pretty commonly present with varying degrees of motor dysfunction? It all comes down to what's within the bones itself. And so, as we said, we have vertebrae, and then within the vertebrae, we house the spinal cord, right? And so what I'm trying to show you guys here is that the spinal cord in all species, in both humans and in canines, and animals in general, what ends up happening is we've got our spinal cord coming down, and it gives off nerve roots in between each of the vertebrae, the junction between each vertebrae, a nerve root will come off. Back on this picture, this was demonstrating the nerve root there. So those come off between all vertebrae. As we go down, those nerve roots ultimately come out, and their job is to innervate things like your rhomboideus shoulder muscles, your triceps muscles, your front limbs, your back limbs. That's basically what those muscles do, or those nerve roots do. They often go in, they innervate things like your abdominal cavity, they innervate things like your bladder, your rectum, your colon, all of these structures as well. So that's the function of these nerve roots. But ultimately, as we go down, what you're going to notice about the human versus the dog is when what's called the cauda equina starts. So the spinal cord will come down in all species and then turn into a bunch of nerve roots, which is called the cauda equina, or horse's tail. And so that's where the spinal cord dissipates. We just have nerve roots, and then those nerve roots ultimately will travel within the spinal canal and then exit the spinal canal, going out to innervate things like your lower structures of your body. So things like your colon, your rectum, your pelvic limbs, your tail in the case of a dog. All of those things are going to be innervated by those nerves that are made up by that are composing the cauda equina. The big difference is when you impinge a nerve root, you have pain. When you impinge the spinal cord, you have paresis or weakness or paralysis. So the big difference here is when that cauda equina starts. So as we go down in a human, we're going to get to about L1 or L2, so much higher in our lumbar spine. As you can see, this is the starting of our lumbar spine. This is the completion. That cauda equina starts very high up in our lumbar spine, so almost right beneath our rib cage. In a canine, however, we've got and this is actually just a cut off of the cauda. This is just the thoracics. This is the end of the thoracic cavity. So T11, 12, 13, this is the starting, this bone right here is lumbar vertebrae 1, lumbar vertebrae 2, 3, and so forth, down to the sacrum. So this picture of the dog is starting right about here, on this picture over here, okay? And so what we're seeing here is spinal cord, spinal cord, spinal cord, spinal cord, spinal cord, and not until we get to L4 or L5, so much farther down, right about here in the human, do we reach the canine cauda equina. So there's many, many, many more vertebrae in this thoracolumbar junction, and also in the cranial lumbar, the early part of the lumbar spine, where you could have a disc herniation. Instead of hitting the cauda equina in a dog, it's going to herniate and put pressure on the actual spinal cord. That's going to be the big difference. So that whether a spinal cord impingement happens or whether nerve root impingement happens, as to whether we see actual pain or whether we see things like paralysis. So again, the spinal cord stops around L1 and becomes this horse's tail, or the cauda equina, in a human. So that's why if we have a disc rupture anywhere in the thoracic spine or in the upper lumbar spine, as long as that disc rupture isn't lateralized and isn't just putting pressure on a nerve root and actually is putting pressure on the spinal cord, then you would see actual paresis or paralysis in a person too. In a canine, though, all the way up until L4, L5 is when we see spinal cord. So it's going to be more apt to have this situation happen. We're actually going to put pressure on the spinal cord and therefore see things like paralysis, versus in a human where you're more apt, a larger percentage of the time, you're just going to impinge a nerve root. Does that kind of make sense? I wish I could see you so I would know if it does, but I hope it does. It's kind of an interesting little factoid, I think. So this is the main reason why, clinically anyway, we absolutely deal with back pain in dogs, especially if not a high percentage of the disc ruptures, or if it is a very lateralized rupture that even though that comes out here and puts pressure on nerve root rather than spinal cord. But ultimately, that's also why we see a higher percentage of actual paralysis from slip disc and disc herniations in dogs. Okay. The next thing I wanted to cover today is going to be strokes or cerebrovascular accidents, or CVAs. So this is now a condition that is definitely something I'm sure you guys have heard of and are aware of, and maybe even hopefully not, but maybe even one of your family members has experienced this, or even yourself has experienced this. And so what we're going to talk a little bit about today is kind of some misnomers. I think the thing about veterinary medicine and strokes is there's a lot of misinformation out there. So I just wanted to kind of clarify some of that, but also introduce you guys to the topic in veterinary medicine as well. So as I told you guys, today's talk was going to focus a little bit more on dogs, or solely on dogs rather than cats. This is one condition where, hands down, this happens far more commonly in dogs than cats. I honestly, I've been doing this for about 10 years, and I don't know that I've ever truly seen an intracranial stroke in a cat. I should have said earlier that in disc disease, you will, gosh, I think I've seen maybe clinically significant disc rupture in maybe 5 cats in my time, so it's not very common, whereas dogs we see it weekly. So both of these conditions are definitely something we see a bit more in dogs. So a cerebrovascular accident, there's 2 main kinds. There's a hemorrhagic stroke, which basically means you have a true either break or an aneurysm. That's also what that's known as, right? A bursting of the blood vessel, and that blood vessel's job is to provide oxygen and glucose to the brain, right? And so it bursts, it ruptures, it doesn't work anymore, it's not supplying that part of the brain, and as a result, you're going to basically you're going to get hematoma formation. So that blood will extravasate from the vessel, form a hematoma, and now you've got a mass effect. So not only do you have a little bit of a lack of oxygen going to an area, but you also have this idea of a hematoma that forms, and that hematoma can act like any tumor in the brain where it's putting pressure on the surrounding structures. So here's a depiction of that. You guys have the brain, a blood vessel, a burst in the blood pressure, and then this hematoma that's formed. Ischemic stroke is the second type of stroke. So this is now where a clot will form in the blood vessel. So now the blood vessel whose job, so perhaps this blood vessel, whose job was to feed the brain, now a clot is forming, a platelet aggregation. So a bunch of platelets get stuck in there, and maybe that's because it's a tortuous vessel, or maybe that's because the vessel has increased plaque on it, so atherosclerosis. But either way, that vessel becomes occluded by a platelet plug, and as a result, you get an ischemia, or a lack of oxygen going to a part of the brain. Here's just a depiction of that on MRI, in a human MRI. So we're looking top down at the person's head. This is about where their nose would be. This is where the back of their skull would be. This whole area here, and I realized I flipped my pictures, didn't I? I'm sorry, this is an ischemic stroke. This whole area here, this dark area, is an area of ischemia. This bright area here is actually a hematoma. And so basically, the takeaway here is that there are 2 types of strokes. We're going to focus much more on one of those types today, though, and the type that we're going to focus on is going to be actually the ischemic stroke. The ischemic stroke between species is much more common than the hemorrhagic stroke is. Most commonly in humans, hemorrhagic strokes are secondary to trauma, so skiing accidents, or being hit by a car, falling off a building, any of those things are going to be things, punched in the face, whatever. Usually trauma is what's going to cause a hemorrhagic stroke. When it comes to ischemic stroke, that's going to be people that, higher pensions, and people that have high cholesterol in their diets, or that perhaps don't exercise, or perhaps that smoke. All of these things that kind of lead to a higher likelihood of stroking in humans. Here's a picture on MRI, again, of a hematoma. This is a hemorrhagic stroke within the brain. This is actually an MRI of a dog. Here is an MRI of a dog with an ischemic stroke. So this part back here is white. Over here you see a white area. And so that's depiction of an ischemic stroke in a dog. So this is a kind of dog brain that you're seeing on this view on sagittal section. So as if you've cut the brain in half and are looking at it on midsection. And then this line here, and this line here is depicting where we are in cross section here. So your cerebral cortex is out here, your lateral ventricle is here, and they're kind of fused together in this dog. And then we've got the hematoma down here in the thalamus. Over here, we've got the cerebellum. We've got an area where this, you'll have to take my word for this, but this, the cerebellum, just looks brighter than it should. And over here, if you guys can see, this looks much brighter than the surrounding tissue here. What you'll notice is there's much more mass effect with this hematoma because there's a big mass-like structure sitting in the brain. Here it almost looks like someone just colored the brain white, and that's what you typically will see with ischemia. As we alluded to, hemorrhagic strokes are much less common between species, so about 15 to 22% of all strokes in both humans and dogs are considered hemorrhagic strokes. Ischemic strokes are more common, so this is upwards of 85% of strokes in both dogs and humans are actually ischemic in nature. Now what's interesting between species is the vessel that's actually stroked is different. So in the case of dogs, the rostral cerebellar artery, so this is an artery that actually feeds the cerebellum, that's the most commonly stroked vessel in the dog. The middle cerebral artery is the one that's more common, is second most common in dogs at 21%. In humans, it's really hard to find this. I mean, not being an MD, I was like scouring, and all of our veterinary literature always quotes that the middle cerebral artery is the most commonly stroked vessel in humans. But I was finding some other information too about actually the vertebral or basilar arteries are perhaps more common than middle cerebral artery in people. So that was looking pretty extensively in lots of different sources in humans. I wish I was there to ask if any MDs were in the room that could give me which is more likely, but it seems like there's a smattering of literature that might support middle cerebral and a smattering that maybe more recently would support vertebral or basilar arteries. So you're probably saying, okay, what are these arteries? Where do they live? What do they do, right? Well, they cause different clinical signs when occluded. So I'm sure you guys have all this is literally from the stroke.org website. So I'm sure when you guys think of stroke, you think, okay, weakness on the side, drooping lip, maybe not being able to speak normally, and then you start to think of, I better get the person to the hospital, right? And those are all things that are sort of ingrained in our head. And this classic picture of this gentleman here is what a lot of people, the most common clinical signs that we see in humans with strokes. And then there's this kind of acronym called FAST, so facial drooping, arm weakness, speech difficulty, time to call 911. So this idea that basically that's going to predicate, you really getting that person into the hospital, right? And ultimately, why these signs or these kind of trifecta here of signs that you see come about is because of the vessels that are more commonly stroked in humans. So here's a picture of the human brain. Here's just on the side view. Here's actually kind of looking at the bottom, actually. I should say kind of looking top down. Well, I should say this is kind of a cutaway version of the brain. You're looking sort of almost kind of, I would say, right around here, if we cut it that way. And you guys in human land cut brains weirdly, but that's basically how this is kind of depicted. And the takeaway here is to show you guys where the middle cerebral artery comes into play. So it comes in here and it actually bathes this kind of center part of the brain. We talked a little about the vertebral artery, which we'll go over a little bit more later. So that's coming up from here. That runs along your vertebrae actually and comes up and feeds the brain. And the common carotid artery, which I'm sure you guys are all aware of its location, comes up and feeds the brain as well. Here's a depiction of looking at the vertebral artery, the basilar artery, so both these kind of converge, ultimately contributing to the circle of Willis. The circle of Willis is a major arterial circle that basically other big vessels come off of to ultimately feed the brain. Within the circle of Willis is the pituitary. So this is the underside of the brain. We're kind of down in here. The pituitary is sitting there, circle of Willis is encompassing it, and we're talking about blood vessels that either go in to feed that circle, which is the basal and vertebral, or that come off that circle, which is the middle cerebral. Here's the dog blood supply. I just think this kind of stuff is really fascinating to compare the two. So this is now a depiction of the dog's brain on the side. Here's the middle cerebral artery coming up. It's been cut away here, but its job is to feed sort of the center part of the brain. The other vessel we're going to talk a lot about today is the rostral cerebellar artery. That artery comes up from this underside of the brain and ultimately mainly will feed some of the brainstem, but absolutely feeds the cerebellum. And all of these are going to be reasons why we see certain clinical signs most commonly in dogs that come in with stroke versus humans, and the signs are often quite different. Here's a depiction in veterinary species in our dogs. And I will say across veterinary species, this is just the dog. So the dog is different than the cat, which is also different than the cow, for example. And so what you guys can see here is vertebral artery will come up. It's going to ultimately go up, form into the basilar artery, and then now we've got, this is their circle of Willis. Coming off that circle of Willis, again, is the middle cerebral artery, but also coming off is the rostral cerebellar artery here. So some kind of taking all of that away, there are actually some similarities as well between humans and canines. One of the big similarities is if you globally look at the external part of the brain and what artery actually supplies all of the other arteries that ultimately go and feed that part of the brain. You're talking about in the front part of the brain, so this is cerebral cortex and thalamus, or the forebrain. The majority of that is fed by the internal carotid artery, or offshoots of that. In the back part of the brain, so now we've got the caudal part of the forebrain and also the cerebellum and the brainstem. That's going to be fed by the vertebral artery. That's going to be the same between humans and canines. Now that's different than cows and cats and horses, but between humans and humans and canines, that's the same thing. Now, there are going to be big differences though too. So though the major vessels that will supply the vessels that do feed these parts of the brain, there's actually differences between what we can see kind of when it comes to movement and it comes to and that sort of thing in animals and humans. So we mentioned in humans you worry about weakness on the side of the body, so we call hemiparesis or hemiplegia, and drooping of a side of a face and all that. One of the differences in anatomy in general between humans, and we're going to include in that primates now, and canines, is the motor system. So the pyramidal system, and not to get too into the weeds here, because I realize this is a fun talk and you're not like in science class, but I think this stuff's kind of fun. So the pyramidal system is the system that actually controls movement in us. That's the major way that major motor pathways that allow us to move from point A to point B. The nerves that control that pathway are emanating from the cerebral cortex, what's known as the motor cortex. So you guys can see if we knocked out ultimately the middle cerebral arteries area that it actually, the job of what it actually feeds and gives oxygen and blood to, you're going to really, really knock out a major part of human movement. And that's why a lot of times we'll picture humans that have had a stroke in a wheelchair, or even just very weak on one side, unable to move or operate one side of their body particularly well, because a lot of times there's some asymmetry to which vessel, the right or left side, that's affected. Canines, however, don't really do that. They don't end up with typically a lot of significant paresis. They often are still walking. I would say in a case of a dog with a stroke, they're often vestibular, so their balance centers take out. And if they can't walk very well, it's because they're so dizzy that they can't walk, rather that they cannot move their limbs appropriately, like in the case of a person. So that's because canine movement is instigated, or the major pathways in canine movement are the extrapyramidal pathways. This is a system that controls movement in non-primates. The nerves that control this movement actually originate from the brainstem. So they originate sort of in this back part of the body. So cerebellum, brainstem, that's going to be mainly the extrapyramidal system. Excuse me, the extrapyramidal system, mainly those cell bodies originate from the brainstem, because a canine stroke typically affects a little bit of the brainstem, but way more commonly the cerebellum. These guys often still have very good movement in their limbs and things. They just look really wonky because it's like someone took the carpet out from under them. It's like they're severely drunk. It's like they've had way too many drinks at the bar that night. And so as a result, they can still ambulate and get from point A to point B, but it's very uncoordinated because their cerebellum, whose job is to regulate your movement, not initiate movement, but regulate it, is affected. So kind of key points for dog owners on this one. Although most cerebrovascular accidents in dogs present with cerebellar vestibular signs, and that's mainly because the most common blood vessel that does occlude in these species is the rostrocerebellar artery. In humans, we see that the middle cerebral is more commonly affected, and or variations on the supply to that vessel are more affected, and as a result of that, they end up more commonly with movement or motor dysfunction. Many other things I should tell you can cause cerebellar vestibular signs, though, other than a stroke. So it's very common, this is where the misunderstanding comes into play, that if a dog presents with an acute onset of balance issues, so what we call cerebellar vestibular signs is another way of saying balance issues or balance signs. A common misconception is, oh my God, they had to have had a stroke. Well, that's not the case. There are many other things that can cause signs that will localize you to that part of the brain. And I've got a couple of them listed here. So anything from low thyroid levels to too much or too consistent use of something called metronidazole, which is a very commonly used antidiarrhea medication used in veterinary medicine. Low thiamine levels, Otitis media interna is a huge one, so an inner ear infection will cause them to look off balance, and sometimes even acutely. Old dog vestibular disease, which is a very, very pretty common disease, one of the more common diseases that will acutely affect a dog's balance. But again, this is completely different than a stroke in that it's usually a much faster recovery for these guys. And then neoplasia and meningoencephalitis, or a brain infection or inflammation, those two things also can cause vestibular signs. So the idea, the takeaway here is just because your dog acutely looks like it has gone to the bar and had too many drinks that night and is vestibular, does not mean that it's not synonymous with saying it's had a stroke. It could have many other of these different possible differentials as well. And the other takeaway I would say is that many times in all the stroke cases I've seen, all of them have done well long term. There's only, I would say, 2 that have not done very well, and that just ultimately had to do with the severity of the stroke itself. All right, and lastly today we're going to talk about seizures. So just to introduce you guys to this topic, I thought it would be remiss to talk to clients about anything in veterinary neurology without mentioning this, just because this is the most common neurologic disorder that we see in our canine patients. It affects 0.75% of the canine population as a global whole. It is one of the more common things that we're going to see, the top one that we see that presents an emergency, a neurologic condition that presents an emergency to our ERs. There's 2 main kinds of seizures, so we can have a partial seizure or focal seizure, and then a grand mal or generalized seizure. A partial seizure is one in which half of the cerebral cortex, here's the cerebral cortex, the thalamus, the lateral ventricles. So we've cut this little dog's brain in half, and you're seeing that half of the seizure activity is localized just to 1/2 of the brain. That's going to result in a partial or focal seizure. When the seizure activity is basically affecting both sides of the brain by way of abnormal discharge, that abnormal discharge carries across the corpus callosum to the other side of the brain. Ultimately, that's going to lead to a grand mal seizure or generalized seizure. So in the case of a focal or partial, a portion of the body is typically affected. Things like fly biting and that kind of a thing. Maybe twitching of one side of the lip or jaw versus a grand mal seizure, all 4 legs frothing at the mouth, often urinating and defecating. Mentally, they're lost normal mentation, and also paddling and things like that. So the kind of typical thing you guys think of when you think of seizure. There's 3 classifications of seizures. One is self-limiting, cluster, and status epilepticus. A self-limiting seizure is a seizure that happens, and then it's a single event, and then it ceases spontaneously. A cluster seizure is one in which you have more than one seizure in a 24-hour period. And that's often an emergency. The reason I say maybe an emergency is for some dogs that kind of live with cluster seizures, sometimes we'll accept a certain number of clusters in those cases, but those are the aberration. By far and away, a dog that has more than one seizure in a day, we consider that an emergency. And then status epilepticus, that is an emergency. So that's a seizure that lasts longer than 5 minutes by definition, or an episode or a patient in which they're having more than 3 seizures without returning to normal consciousness in between those seizures. How to diagnose the cause of seizure is basically starting with some blood work, so making sure electrolytes and liver values and all of that look normal, making sure platelets and blood counts are normal and things like that as well. Sometimes we'll do some liver function testing because elevated liver values can also lead to seizures. It's cause hyperammonemia, which increased ammonia in the blood will go to the brain, and that can cause some issues and can cause seizures. And then advanced imaging. MRI and CT both exist for this purpose. I would say by far and away MRI is going to be the preferred method because MRI is always better at looking at soft tissue than CT is better at looking at bone, and ultimately the brain is a large lump of soft tissue. The reason this little gentleman is on this slide kind of guiding us today is that Border Collies and Australian Shepherds are 2 of the more common patients or breeds that present with idiopathic epilepsy, and also 2 of the harder breeds to control. Their seizures, though due to malwiring, rather than a tumor or something like that, they usually have a disease called idiopathic epilepsy, so epilepsy of unknown cause. Their seizures tend to be the type that become refractory and require more than one anticonvulsant throughout their life and through treatment. So what should an owner do if you are concerned your dog has had a seizure or is having a seizure? Protect your dog, protect yourself. meaning try to prevent your dog from falling down the stairs, from falling off the couch. When I was a kid, one of our cats used to have seizures, and she had reactive seizures. So basically, reflexive seizures, I misspoke, which basically we would get the little crinkly, Pounce Cat's treats, the Whisker Lickens actually at the time. We'd open the bag, and the sound of the opening of a bag, much like a human with epilepsy secondary to strobe lights, for example, the opening of that sound, it's an audiogenic seizure, that sound would cause her to go into a seizure. She always ate on a cat counter, so we got to the point where we learned this would happen. We'd have to go in the other room, open the container so she wouldn't hear it, come back in and feed the treats so she wasn't flying off the counter in the midst of her seizure. So we had to kind of go through different protocols to kind of protect her. You want to protect yourself. So many times owners just want to help their dog. They want to go over and help hold them and things. Just make sure you don't want to get bitten. Your dog's not aware of what's going on, and you don't want to get bitten or get injured while you're trying to protect your dog. And if it doesn't look like a normal episode, like what we described earlier, then snap a video of it. A lot of times that will help, because then you can show that to the veterinarian, who could kind of discern whether they think in fact it is a seizure or not as well, and weigh in on that. And then ultimately you want to make sure you take your dog into the veterinarian to have them look at the patient and make sure that there's nothing that they can determine as the sole source that is something that we could treat right then and there, and kind of to guide you there on further diagnostics and treatment in those situations. As for therapy, if there is an underlying cause other than idiopathic epilepsy, which again is epilepsy of unknown cause, but if there is an underlying cause, we want to try to treat that cause. For those that are idiopathic epileptics, which is basically a malwiring of the neurons, then for those patients, you do want to monitor for further episodes. You want to, potentially institute, anticonvulsant therapy. And then there's at-home kind of therapies that we can give too to kind of prevent or lessen the likelihood of having more than one seizure at home. And that at-home management is often medicinal in nature. So we can give things like diazepam or Valium rectally, midazolam, it's kind of blood brother, another benzodiazepine that can be given intranasally. There's oral medications we can give to kind of, again, prevent the likelihood of more than one seizure happening at home. Typically, those medications are prescribed when a patient is a known cluster dog, and not necessarily doled out for those that just have one single seizure episode. And again, for most dogs that have cluster seizures, then that is considered an emergency and a time when you should go to your veterinarian. Okay, thank you guys very much. That was sort of the end of our talk today. I just want to leave you with a picture of our new hospital, because we're really excited about it. So the neurology section, or neurology wards and area will be right around here, I think, in the new hospital. And so we look forward to being able to treat anything that you guys need treated, and see you if you're having any issues with your patients. I hope to not see you, because that would mean your dog or cat does not have a neurologic issue, but certainly we are there for you guys if you need anything. And thank you so much for your time. It's been really fun to talk to you today.
Thanks so much, Dr. Thomovsky. To echo her comments, in case you didn't know, our college is expanding with the new David and Bonnie Brunner Veterinary Medical Hospital Complex. This is adding nearly 165,000 square feet of space to better serve our clients' needs. Feel free to keep up with our neurology team and our hospital progress at the provided links right here. We have our neurology site, our contact to reach out to us anytime at pvmgiving@prf.org, as well as our hospital site, the leaveaprint.vet. I hope that we will see you all again tomorrow night for our final presentation in this series, when Dr. Catherine Scott Moncrief provides insight on diabetic treatment. Thank you all so much for joining us tonight. Have a great evening.